All right, Journal Clubbers, welcome back. It is another Monday here at the Overrun. Today we're going to talk about pacemakers. First article that we found, this is coming from Josh Kimbrell. So we looked at this study, and I'm going to bring it up on the screen here in a moment. Dan, you actually found this. It's interesting in what we look at here, where the way that this reads, this is talking about transcutaneous pacemakers and failure to capture. So as we're looking at it, right, there's some important stuff here, like transcutaneous pacings for unstable bradycardia has a 2B recommendation from AHA. We'll talk about that in a moment. But this particular study was retrospective. It was an urban hospital-based network between March 21 and March 23. The only red flags that I saw in this going through it, very small N. They only had about 23 patients that they enrolled in this, which again is probably more of a function of there's just not enough people that they were able to study here.
More sophisticated people would call it underpowered.
Yes, there it is, an underpowered study. But they had some people get out with a good functional discharge. They had some false captures here. First thing is, again, these findings suggest that a high proportion of patients who undergo transcutaneous pacing are at risk of false electrical capture despite a recorded palpable pulse. While our analysis is limited to a single EMS network, these data raise concerns regarding the incidence of pre-hospital false capture. Further research is warranted to calculate the incidence of the false electrical capture to evaluate mitigation strategies. So, Dan, let's get into this a bit. So obviously, what this study essentially found was that there's a fair amount of patients who need to be paced. They have unstable bradycardia. EMS gets them, throws on pacers, and the provider feels as if they felt a pulse. So they document that there was a pulse recorded, and it turns out that's not always the case. So again, here, 19 of the 23, it's almost 83% of the patients who had pacing done had false electrical capture, despite all 23 having documented mechanical capture for pulses. So as we're pacing somebody, and this is something that is taught like a lot in medic school, is you have to make sure that you have this electrical mechanical capture. So what I think ended up happening in this study to a lot of the providers is it's difficult when you're pacing somebody, especially at say like a rate of 70, right? It's difficult to differentiate your pulse from the patient's pulse. So you can look at it on the monitor and you kind of be like, I feel like that's probably captured. But if you're pacing at 70 and your heart rate is about 70, it's kind of hard to tell the difference between the two.
I kind of, I looked at this and I was kind of going back and forth like why this was happening. And I think what it comes down to is pacing is one of those, low frequency things. We don't do it a lot. I mean, I only paced 3 or 4 times last year. It's not something we do all the time. It's something we practice in ACLS, and maybe you're doing it, maybe you're not. If you're taking the online ACLS, as I just did for my research, you're not even getting hands-on time with the monitors anymore. It's really very different. I think the thing to remember is, with these patients, they do have an underlying pulse. This is not a difference where we have like a resuscitation where you have somebody who didn't have a pulse, we defibrillated, and now, it's there. Like there's an underlying pulse here. So, this is the patient that kind of looks crappy. They're sitting there. They've got a resting heart rate. Their heart rate's at about 30. You're amped up. You're getting the IV. You're doing all the stuff. You're putting the pads on. You're setting it up. You're worried about pain management because you really don't want to make the patient uncomfortable because, some of these people might need higher energy levels. Nobody's going to convert or start pacing at 10 milliamps. It's going to be more.
No.
And you put your hand on their carotid or their radial, and you're like, oh, there's a pulse. So I must have mechanical capture. This is where you really got to buckle down, and you've got to be very concerned. And I think this is what happened with these patients in this cases, is that it's not just enough to feel for a pulse that is there. We know there's a pulse that's there. The problem is this pulse is too slow. Does the pulse correspond to what you're seeing on the monitor? And something that I use that's really helpful is when I'm getting that pulse, I'm not looking at the patient. I'm looking at the monitor. Because when I see a complex, I should be able to feel a corresponding pulse with each complex. If I don't, something's not right. So either I have to up my milliamps, I have to look at the patient, I have to check my pad placement, something's not right. remember that pulse will correspond to the pacer spike and also the underlying rhythm, not just the underlying rhythm. So that's mechanical capture. Another thing that works that I found that works real well too is look at your other vital signs. Look at what your blood pressure was. Did your blood pressure go up? Did your cardiac output increase? Put them on end-tidal. End-tidal is perfusion. We see this all the time, and there's a lot of people that only use end-tidal for intubated patients, but it can give you so much more information on differential diagnoses. Are you perfusing? Are you doing better or worse than you were? I find that if I've got a patient and I've got a corresponding pulse and I've got a good normal end-tidal, we're pretty good.
And it is one of those things that, again, can be very kind of confusing for a lot of providers. But if you're not sure and if you're feeling for this mechanical pulse, one of the things that I try to do in my practice is, that if you breathe faster or slower, your heart rate will go faster and slower. So I tend to kind of hold my breath for a little bit to see if I feel that radial pulse and make sure it's not to my fingertips. But also, I wonder if we put too much focus on the radial pulse, and you can still feel for a carotid pulse. You can actually put your scope over the sternum and listen to heart tones. But another big, and again, when we talk about looking at the patient, you want to look at all things. One of the things that was important here is for patients with electrical capture, the median change in systolic blood pressure was 40 millimeters of mercury. For patients with false electrical capture, the change for the systolic was -1 millimeters of mercury. So as you're working on these patients, if you're not sure if you have electrical capture, and obviously there's ways that you can kind of, fight through this, right? Where it's like, well, let's see if we can adjust the milliamps a little bit. Maybe we adjust the rate a little bit, see what we can actually do. The first thing you're going to see is the best way I can describe this is your EKG is going to look wonky as hell, right? Once you get that electrical capture, right? So what's going to happen is, keep in mind that we have to get that impulse to fall in the R wave, right? So you'll have your cardiac complex, and then you'll see a pacer spike, and then there'll be a complex and a spike, and maybe they get a little bit closer. Then once you actually get that capture on the monitor, what happens is it starts looking more like a pacer rhythm for obvious reasons, right? But if you're not sure, you're seeing like, oh man, it just looks like a wonky rhythm here, check the patient's blood pressure, which is something that we can do anyway, right? If your first documented blood pressure was 90/60, and you think you have capture in this patient now, and now their blood pressure is 130/60, well, now it's something that we have to think about, because you have evidence that supports that capture, right? And right. That's one of the things to try and consider there. What do we think are some other decent tools to confirm that we have electrical capture, aside from, and I don't mean to say like don't stop looking at the monitor. Obviously, we're going to keep evaluating the monitor, but we do have some of these changes here. But if you're not sure, Dan, what are some of the things that you do in your practice to try and confirm that you have that capture?
First and foremost, look at the patient. If you got in there and this patient was sick and not feeling well and lightheaded and dizzy, and now they're finding that resolution of those symptoms, or they're telling you they're more aware of their sensorium, that's a good sign to me. If your brain's perfusing better, I'm pretty good with where we're at. If I've got good skin color, do I have good capillary refill? This is like back to the fundamentals, guys.
You're right. Like it's the basic stuff. Does the patient look better than they did when I got to them?
Absolutely.
Like that's all it is.
Again, I love end-tidal. I love using end-tidal. We have nasal end-tidal in my shop, so I use it. I would say 75-80% of patients get an end-tidal because it tells me a lot about the perfusion status. So I want to use that. If I get a bump in end-tidal and I get a bump in mentation and I've got that wonky looking ECG and I've got corresponding pulses, I'm really confident of my mechanical capture, and I'm less likely to have false electrical capture.
Yeah, I think that's right. I think that, I don't know, is this something that, to your mind, you consider a halo kind of event? Because it's certainly not to the same level as like chest decompression or, even using a traction splint. I wonder if.
I think it could be. I think based on based on patient acuity, some of these patients are really, really sick. Some of them don't present as sick as you think they are. We've all had that, that little old lady, and she's lightheaded and she's just not feeling well, and she wants to finish her shopping, and you put her on the monitor, and boom, she's 3rd-degree block, or
Yeah.
2nd-degree type 2 with a pressure at 80. It's like, oof, But
Yeah.
I think it could be. It's definitely something. If we're doing this, we obviously have decided there's some sort of cardiogenic issue that's impairing perfusion. We have to increase perfusion. We know bad perfusion is really bad. Yeah, I think we have to. I think we have to start getting into a systematic way of, when we do these things, that we're checking all these other clinical findings. Also cross-checking. Like, we do this with intubations. We do this with a lot of things. That, especially when you have a crew, whether you're paramedic EMT, paramedic nurse, whatever you are, you're going to cross-check with your partner. Like, hey, do I, if we resuscitate somebody and I get a shock and we get an organized rhythm on the monitor after we do our compressions, I'm going to take a look, and I'm going to say, I'm going to feel for a pulse. I'm going to say, yeah, I think we got something. What do you think?
And I think that's important. If you're in a system that has 2 providers, that's part of the catch, though. Because if you have a system where you have a paramedic and EMT, that might be a little more sketchy.
But, and I'm assuming that the vast majority of EMS providers, except for your fly car people who get there, but you're still going to have help coming in. You're still going to have the, hey, what do you think? We do this with lung sound. Something as mundane as listening to someone's chest. Like, is that real? Is it a wrong guy? Or is it a little bit above everything? Hey, take a listen. Tell me what you think. I just think a lot of it gets to be sometimes hubris. I think we think what we think, and we think we can't. Not that we can't show weakness, but that, oh, we did it. It's fine. The machine took over. We're good. Like,
yeah.
I think you follow up and document. And more importantly, document this stuff. When you do your PCR, when you're talking about starting pacing or something like that, what was the results of the pacing? Did you have electrical capture? Did you
Did they improve?
Did you see a complex after every pacer spike?
Yeah.
Did you palpate a pulse? Was that rechecked? Did your vital signs improve? Did your pacing get improved? Did your end tidal increase? It's a couple sentences. It takes 45 seconds on your chart, but it's a huge difference down the line.
And again, we talk about watching your patient, and this is another thing where I think in a setting like this, where you have someone who's fairly sick, being in the back of the truck with them can be really stressful. So there's, 5 or 6 different things you have to do. I think a lot of times we kind of fall back on default, right? Where we know that the machine is supposed to be giving us both electrical and mechanical capture. So at some point, we kind of we imagine that there must be mechanical capture at this point. Sure. I mean, I've had people where, we've had to get up to 110 milliamps to actually get capture on them. And I want to tie this into kind of the second part of this, which is, in those settings, how do you feel about pain management for those patients?
Oh, I think it's a necessity. I think, it's probably something you can defer down the road if that patient's unconscious or really out of it, and you have to get that perfusion augmented. But once these patients, once you get this mechanical and electrical capture, and all these other clinical findings have been validated in your patient, now you got to start thinking about putting some pain management on board. If this is a patient that is with it, that is alert and oriented and talking to you and you're doing this, absolutely front load that with some pain management. I like using fentanyl, 50 micrograms to 100 micrograms. 1 microgram per kilogram is your usual dose around here. And I'll do that.
So why? Because I would have my choice on that would have been ketamine. So I'm interested why fentanyl over ketamine.
I like.
To be clear, I don't think there's a right answer. I don't know if there's a right answer. But
I like fentanyl because it's very cardio neutral. It's something that I can really I can give little pushes. It's quick on. I can do it quicker than if I rig up a ketamine drip. If I'm doing pain management ketamine, I have to, it's 0.2 to 0.3 milligrams per kilogram in 100 mLs, and you run it over 20 to 30 minutes. For us at my place, that means a pump. That means if you're doing it correctly, it's a pump. There's also that I don't know partial dissociation. Is that going to put me if I mess up ketamine, I put them in a partial dissociation? Is that could cause me more drama? I've gotten good results with first line as fentanyl, little pushes, 50 to 100 micrograms, and then just keep giving little pushes as as their comfort level decreases. It keeps them oriented. It keeps them functional. It works 15, 20 minutes at a clip. And I find that I usually don't have to redose until we get to the ED. Ketamine's a great second. I love ketamine as a second line pain management med. I don't know that it's real. It can be a first line med. I get it, but I don't like using it that way.
My thinking with ketamine, especially in someone who needs to be paced, is I know that they're already, their cardiac output isn't sufficient, right, for whatever reason. So they're already hypotensive. They're already probably a little bit bradycardic. My only thinking with ketamine over fentanyl is ketamine might have a little bit of a positive effect of actually like constricting vessels and raising the blood pressure a little bit. It can also have a negative effect on dose dependency, and also then fentanyl can have the same negative effects too. It's more of an academic question where, fentanyl is going to knock out their pain, which is fine and something that they need. Ketamine is also going to have pain effects, but might also disassociate them a little bit more. But again, both of them come with risks. You have to monitor airways and all that. So the reason I say I prefer ketamine, I completely understand fentanyl, and I'm not convinced that there's a right answer one way or the other. But when we're looking at patients,
this is the fun part of being a clinician and knowing your tools, knowing your toolbox, and having your preferences. Like I said, I'm basing it off my experience, off the things I've done, the times that I've dealt with these types of patients. I've found that little doses of fentanyl do really, really, really well to keep them comfortable and to keep the pacer going without any negative cardiac effects. I get the other side of the ketamine thing, and I know everybody talks about ketamine having that sympathomimetic effect, or that that boosting your blood pressure. Again, that's not the reason why I would give it for this. And I've also had cases where I've given ketamine and that's gone the other way. So I think it's 6 of one, half dozen of the other. It's what works for you. The one thing I would say, if I was doing a longer transport, like our friends out west, if I'm looking at a 45-minute transport with somebody on a pacer, on a transcutaneous pacer, maybe that low dose pain management ketamine is a really good choice, because I know that will give excellent analgesia, and I'll have it for maybe a longer bit of time.
Well, and that might be an interesting conversation too, where if you're in a state like, say Montana, or the Dakotas, that has a large transport time, are those patients that you pace them, but you also say like RSI them to keep them down for that transport? Again, not suggesting one way or the other, just a thought experiment to go through it. But one of the great kind of lies that we've been told in EMS education is that you cannot interpret an MI through a paced rhythm, and that is not true. So the second paper that we're going to look at today, this is coming out of Annals of Emergency Medicine, and this is from 2023 of January. So this case study talks about a 65-year-old male who called for chest pain and diaphoresis. The team found him hypotensive and bradycardic, and this is his EKG strip. So looking at this strip, right, we just see it just looks ugly, right? Like, this is just not pretty. This almost looks like a third-degree block, right? You've got all these P waves through here. You've got
more Ps than QRSs. The Ps have the same relationship, but there's no relationship to the QRS. I'd call this a third.
Absolutely. And when we were talking about really ugly rhythms, right, we see here on this second strip, this is the post-external pacing, right? So there's not great capture, but again, the point is that when you're seeing capture, it is kind of ugly. Before we get into the conversation, I am going to scroll down to a couple more of the EKG interpretations. So this is the actual strip of the patient who is paced. So when you're looking at this strip here, you see this is our pacer spike right there, and then you've got this really ugly, almost square complex. That's what a paced rhythm that has capture looks like. So earlier when I was saying it's going to look like this really ugly rhythm, this is usually what that capture is going to look like. So going through these EKGs, we also see here on the top, and I believe this is leads 2, 3, or 1, 2, and 3. But bottom lead here, which is 3 or AVF, you see you've got this little elevation here, right? And it's about 2 millimeters according to the paper that it's on. So one of the great lies that at least I remember I was told in my education is that you can't differentiate a paced rhythm from a STEMI, or you can't read a STEMI in a paced rhythm. It's just incorrect. Because again, as you look through here, we see that this patient has these elevations before they're being paced. But even as you go down to this paced rhythm here, right, as you see their paced, you see these differences in these ST segments and how they're wide, right? They do go up very, very high here. You see what looks like a little bit of a bundle in this strip here. So you are capable of looking at this patient and seeing what their actual EKG looks like. The teaching points from this paper, again, you want to make sure that you actually have electrical mechanical capture. When using a pacemaker, the mere presence of spikes does not mean the patient is being paced. And we want to place the pads, say that 5 times fast, closer to the heart. Now, one thing that's important in this paper that I want to mention, placing pads close to the heart, e.g. the anterior posterior position, can potentially enhance ventricular capture at a lower output. Now, this debate has existed in the cardiac arrest literature for a while as far as defibrillations are concerned. But it appears to be that if you have an AP placement of your pads, that electricity has less muscle tissue to fight through, less adipose tissue, less muscle tissue. So it goes right into the ventricle. Having the AA placement will put the signal through the heart, right, diagonally, but it won't necessarily hit the right focuses or foci in the heart to cause the patient to be paced properly. So lots of complex stuff. Dan, when you have someone who's in a block, like what would be your clinical pathway for this? You have a patient who's presenting, they're hypotensive, they're diaphoretic, they've got this elevation. What would be, in your mind, what's your algorithm? And then we'll compare notes and get out of here.
Well, I thought it was interesting that this article was talking about finding STEMI in transcutaneously paced patients, because I got to be honest, that 3 leads coming up on my monitor right now. I'm considering STEMI right now, especially with the patient presentation that I've got. I'm going to probably, as my partner's getting the pads or somebody's helping me get the pads ready, I'm going to be doing a 12 lead. The easiest 12 lead to do is the one before we start introducing electricity into the equation. Try to get a clean 12 lead, try to get it transmitted if you do that in your system to alert the PCI lab that you're going to be coming in with this patient. And I think this is I'm pretty confident calling a STEMI on this just based on what I saw in the 3 leads. I think that's right. I think if we had a 12 lead, I think it would confirm our suspicions. And again, all the clinical findings. It's not just one thing. It's all this stuff, and it comes into a ball, and you're like, okay, this is what it is, right? Or this is the most dangerous thing it could be. This is what we're going to treat for. So this is the patient that, for me, they're getting 2 IV lines. They're going to get aspirin. They're going to get pain management. They're going to get some fentanyl. Again, this is not somebody nitrates. Blood pressure's too low. It's not going to help them here.
Yep, they're already hypotensive.
Right. That's the thing you're going to defer in this care plan. And you're going to get them on the road. We're going to start going to a place that can do PCI, that's got a cardiac cath lab, because most likely we're looking at a lesion in a coronary artery. We got to get them somewhere where we can get that.
Or several.
They could have multivessel disease, sure. This is a good consideration. If you have the choice between the local hospital that maybe does the rescue cath, or you're close to a place that does cardiac surgery, might be a good discussion with your medical control or your medical command physician. Hey, maybe we should take them here. On the other hand, if that's not something that's in your playbook, then I'm going to the closest place that can handle this patient effectively, and letting them know we're coming in.
And knowing what resources are available to you at your hospitals is essential, right? Because if you have someone who has this presentation, right, they have an MI and you're pacing them and they're still hypotensive refractory to that, your community hospital might be able to stabilize them a bit. But if you're fortunate enough to live in a state like we do, where in New Jersey, you can't throw a rock and not hit a hospital. So if you're in a setting where, okay, well, I'm 5 minutes from this hospital and I'm 10 minutes from this hospital, which is a comprehensive center, that it is a conversation to have. But it's the other thing where it's like, well, is this patient likely to only have one problem? Given all of their history. So something that's really important to consider: where you're going, why you're going there, what resources they have. One quick note that I do want to make before we get out of here is that a lot of commercial pacemakers also have a look-through option, where as you're pacing the patient, you can actually take the monitor and hit a button to see what the underlying rhythm is underneath the pacer spikes. So this is that's a whole other conversation of like knowing your equipment before you get into the patient. But again, there are some fun little tools that we can use to see what's going on with the patient better than we might understand it anyway. But pacing people, I don't know that it's a halo event. Like we're getting there. I do think it would be effective to teach it that way, but I don't know that that's actually realistically where we're at with it. Just because this, again, you see one study. But I do hope that this was helpful to everybody. If you are pacing somebody, make sure that you have electrical and mechanical capture with those patients. Make sure that you're not adhering to your own biases when you're trying to check for a pulse. And remember that everyone that told you can't read an MI through a pacemaker was lying to you. But that's the Journal Club for this week. We'll see you all next time.
See you later.